Presentation is Dr. Jethani. Is that loaded? So, Dr. Jethani, your time starts now. The topic is uh, quarantine, myopic progression in school children after COVID-19, home confinement. This is the All Gujarat Ophthalmological Society with us.
Yeah. So as I had the previous paper on the incidence of myopia and prevalence of myopia, which is constantly increasing, and there have been multiple of articles which suggested that low outdoor activities and near work is one of the most important factors in progression of myopia. So this was a wonderful meta-analysis done and was published in BMC Ophthalmology 2020, where they suggested that one of the most important factors in progression of myopia is indeed low outdoor activities and near work. So with this background and with the lockdown that started in India due to COVID-19, which raised the number of hours the child would be inside, there would be imminent near work along with increased digital screen time and low outdoor activities. So there have been some studies which have suggested that there is a subsequent myopic shift in school going children after COVID confinement. We had around 36 children between the age of 6 to 12 years who were being followed up at our clinic and who were already diagnosed as myopes and were progressing. Despite we tried to convince them that they should be using some intervention for myopic progression, these were children who were not using any, they were not using any sort of therapy for myopia. And so these were ideal. I mean, we were not aware that there would be a lockdown in future. And so these were the children which became ideal children, where we had all the data of them pre-lockdown, and now they were home confined. And so we got a detailed ophthalmic evaluation done of them, as they were already, we were trying to tell them that they should undergo some myopia therapy, but they were not. So we did descriptive and inferential statistics which were performed data with, because this was a non-normal distribution, so instead of representing it with mean, we are representing it with median with first and third quartiles. And so this was our observations. The mean age of 36 children was around 8.7 years. The median progression in myopia per year, the median was 0.75 diopters, and post-lockdown it was 1.25 diopters. Being a non-normal distribution, the median is being quoted. Similarly, for axial length, prior to lockdown, the median progression was around 0.24 millimeters, and post-lockdown it was almost 0.63 millimeters in these 36 children. So there was a huge influx of axial progression, a direct correlation with near work, ocular strain, increase in indoor timings, and increase in axial myopia has been described by various co-workers. In fact, during lockdown, there was a wonderful letter editor by Sumita et al. From Nayan Netralaya, where they suggested that there could be, they in fact predicted that there will be a spurt of progression in myopia. A similar increase was seen by Wang and their colleagues. The only problem in their study was the children which were seen were not the same set which were examined pre-lockdown. So there were different set of children. They just got the incidence pre-lockdown and post-lockdown and suggested that the incidence of myopia has increased post-lockdown. Another wonderful article of Chang et al. Was published, where they did use the same set of population pre-lockdown and post-lockdown. However, they did not do a cycloplegic refraction and biometry. So it is very difficult to know that the near work can also cause accommodative spasm and a false sense of belief that the myopia is increasing. So you have to do a cycloplegic refraction all the children whom you are studying. So the strength of our study was that it was done on the same set of children who were assessed at multiple intervals without any loss to follow up. So we could show that it was indeed lockdown which was the important factor for the increase in myopia. Maybe imminent near work, maybe the loss of outdoor activities, but definitely quarantine was one of the risk factors for that. Few limitations of our study were that it was retrospective in nature, and we would have been happy to have a larger sample size, but at this point lockdown was unpredictable and unplanned, and we believe that these children can be followed up further and reassessed again to see whether now, once the lockdown is over, whether that makes a difference or not. So our study shows that myopic progression was significant during the quarantine period, and therefore it calls for strategies to prevent this, not the quarantine but near work and outdoor activities, which should be up on other agendas like National Program for Blindness, which should make it a national myopia prevention program with the help of Orbis and Vision 2020. Most of us are associated here in community with them, so that it would be a good call to incorporate this also into the program for blindness. Thank you so much, and thank you for your time.
This is a competitive section. We will not have any questions on the paper. So we'll move on to the next paper. Then we can do that if we have time later on after this. The next one is trash to treasure.
We have to announce this first.
In the meantime, I request our chairman to please announce the winner.
Sir is the chairman.
Dr. Suman. Who got the highest?
This number.
Number one. What is the power? 380.
380.
The winner of the
The
session.
winner of the last session is Dr. Parikshit Gogate, a 8-year longitudinal study of 44,535 individuals to see reaction in blindness and vision impairment. So he is going to the
Number 3 speaker.
number 3 speaker in the session, next session.
Good afternoon everyone, myself Dr. Maheshwari. I'll be talking on Trash to Treasure Red Camp, Treasure to Save Sight amidst pandemic. Diabetes is a global epidemic disease and India is considered to be a diabetic capital of the world. It is projected to grow to a 101 million by 2030 and 134 million by 2045. Proliferative diabetic retinopathy and diabetic macular edema are two main sight-threatening components of diabetic retinopathy. The National Survey of 2015 to 19 reported that 16.9% of those with diabetes mellitus had diabetic retinopathy in India and 3.6% had sight-threatening diabetic retinopathy. Diabetic retinopathy meets the WHO screening criteria. The criteria for DR screening includes in type 1 diabetics within 5 years after diagnosis and annually thereafter, type 2 diabetics first retinal examination at the time of diagnosis of diabetes mellitus and then annually thereafter, women with gestational diabetes, not a known diabetic but with random blood sugar of more than 200 mg per deciliter or HbA1c of more than 6.5%. The aim of our study was to evaluate diabetic retinopathy screening using Trash to Treasure Red Camp at vision centers in rural and underserved areas in Tamil Nadu for teleophthalmology during pandemic. This is a prospective hospital-based study conducted at 11 vision centers over the time span of 6 months. Patients who visited vision centers were selected and informed consent was taken, detailed history and RBS was checked, visual acuity and refraction was done, ocular examination was done, and dilated fundus photography was taken using Trash to Treasure Red Camp. Image was remotely analyzed by retinal surgeon and graded, and patients requiring intervention were referred to the tertiary hospital. To tell about the results, over a period of 6 months in 11 vision centers, 1,904 patients were screened, and which included 851 diabetic patients, out of which 15% were already a known case of diabetic retinopathy and 85%, that is 61 cases, were newly detected diabetic retinopathy. 49 of 72 patients were referred to tertiary eye hospital for further examination and management. The mean age of patients in the study group was 54.4 years. Out of 49 referred patients, 14 were lost to follow-up. 56 eyes of 35 patients were diagnosed to have vision-threatening diabetic retinopathy and was referred in need of treatment. After clinical examination and multimodal imaging at retina clinic in tertiary hospitals, 45 eyes, that is 80.35%, were advised treatment. These are some of the images taken during the screening program. The treatment plan included panretinal photocoagulation, intravitreal anti-VEGF and steroid, and vitreoretinal surgery. Coming to the discussion, with the epidemic of diabetes mellitus related visual impairment and blindness looming on us, it is imperative that we take all measures to reduce the burden of sight-threatening diabetic retinopathy. At the height of the pandemic, elective services like community-based screening of diabetic retinopathy was halted universally to prevent community spread of COVID. Early detection of diabetic retinopathy by regular screening can help in slowing the progression of any diabetic retinopathy to sight-threatening diabetic retinopathy with good control of modifiable risk factors. The models of diabetic retinopathy screening includes hospital-based, community-based and teleophthalmology. At present situation of pandemic, teleophthalmology plays a very important role in screening of diabetic retinopathy patients by bridging the gap distance time and burden on manpower. The available devices for screening of diabetic retinopathy can be divided into tabletop, handheld, and smartphone-based devices. These are some of the studies and international acceptance and concurrence that the screening of tests for diabetic retinopathy should have at least 80% of sensitivity, 95% of specificity, and less than 5% technical failure rates. Coming to Trash to Treasure RedCam, it is a simple, affordable, portable, wireless, do-it-yourself kind of a device which is done using a empty hand sanitizer bottle. It needs a mobile holder, a black chart paper, smartphone, and a 20 diopter lens. These are some of the images taken using Trash to Treasure RedCam. These are images of diabetic retinopathy. The Trash to Treasure RedCam has been able to pick up findings like dot blot hemorrhages, hard exudates, soft exudates, superficial hemorrhages, IRMA, NV, NVD, tractional bands, laser marks, and CSME. Although it can miss the diagnosis of mild NPDR, it has been able to diagnose sight-threatening cases. The parameters on which a successful teleophthalmology program can run are diagnostic accuracy and cost effectiveness. The study conducted to analyze the efficacy of Trash to Treasure RedCam in diabetic retinopathy screening showed a sensitivity of 88.4% and specificity of 100%, and it cost only Rs 500 in making this. It also reduces travel and time, cost, and loss of income of patients. To conclude, Trash to Treasure RedCam is a smartphone-based telescreening device with very minimal investment which can be used in peripheral centers associated with multi-speciality eye hospital for screening. It is time that diabetic retinopathy screening evolved into ophthalmologist-supported rather than continue to be an ophthalmologist-led screening program. The overall final cost benefit is larger than conventional screening programs. These are my references. Thank you.
Thank you. Now we request Dr. Gogat to please come.
He has to present it again.
Do we need to hear it? I think we just heard you, so we can skip the second. What do you say? Same paper you're presenting, right? So
maybe we can hear it again.
okay, let's hear it again.
Yes. But ethically, yeah, because you have to compare the three.
And also it'll be a refresher course.
Respected chairpersons and learned audience, it's a 4-year-old longitudinal study of about 45,000 individuals to see the reduction in blindness and visual impairment. This is a study we have done in a low-income area in Pune. We set up a vision center to serve the population and we re-examined the entire community after 4 years. This was based on the LV Prasada Institute model, and Dr. T.P. Das had given us his technical guidance and blessings, and Operation Eyesight Universal had done it. Vision centers form the base of the pyramid, but there has been no study which actually showed the impact that a vision center has made in the community. So we've tried to do it in Pune because we know vision is very, very important. Here we have these 4 healthcare workers or ladies between the age who have studied till 5th to 10th standard. They have gone and examined people's vision in their homes. Those who had vision less than 6/18, they were referred to the vision center. Those who did not come to the vision center, the optometrist has gone to their homes, and the optometrist has gone with a autoref, a handheld slit lamp, a rebound tonometer, and has done the home visit. And anybody who has not improved to 612 has been seen by an ophthalmologist, and Dr. Supriya Fadke, she assigned a cause of blindness to those whose vision did not improve beyond 660. And these are the results. So 4 lady healthcare workers, 1 lady ophthalmologist, 1 lady MSW, and it was heartening to see that 60% of the OPD, 58% of cataract surgery, 58% of specs prescribed, and even 57% of specs sold have been sold to women in this vision center in a 4-year period. This is the age and gender distribution of the 2 cohorts. The difference that you see between the 2 figures, 44,535 and 43,708, is because in that 4 years, 222 had died, 396 had moved, 28 refused repeat examination, only 181 were lost to follow-up. And this is the visual acuity of the individuals examined in 2015. 0.26% is the prevalence of blindness, which is quite less. But then it is for all age groups. But here in women, it is 0.3%. That is 1.5 times the blindness in men. And this is in a place like Pune, which is supposed to be, relatively very gender neutral and relatively, you can say, socially developed. And of course, in the age group of more than 75% blindness, in more than 80, almost 3% of blindness. Now, we didn't look only at the better eye, because in better eye, sometimes you miss out on the worse eyes. So when you look at the worse eye, the prevalence of blindness is 0.72%, which fell down to 0.44%, almost a half reduction that we were able to do in 4 years. But here again, those who are more than 70 years of age, almost 10% of them have one eye that is blind by WHO standards. Again, women had more blindness, and this is statistically significant. Older groups had more blindness. And head of the family, we believe he's the head of the family, he's the earning member, but they are more likely to be blind because they are older. Again, when we set up the vision center, the impact is definitely there. But women still have a higher prevalence of blindness, and we need more studies to find out why that is so. The prevalence of blindness has reduced even though the average age of population has increased by 4 years. So that is good. And of course, more women visited the vision center. Again, in causes of blindness, first we offered them subsidized surgery at 3,000 rupees. If they couldn't afford, free surgery. But even with them, even after 4 years, 40% of blindness is because of cataract. So just doing good surgery, free surgery is not the answer. There are more psychological barriers that we have to understand. And of course, strength is that more women accessed, comprehensive, reliable service which pays for itself. And most importantly, unlike ICAMS, it gives person-based, individualized care to the community and allows for health education, health promotion, which is very important for myopia, for glaucoma, for diabetic retinopathy. They cannot be solved just like that. And all the other prevalence studies that we quote, all of them are based on stratified sampling. This is a small study in which the entire universe, the entire population has been studied. The RAB studies study population only 50 years plus. We have done it for all the age groups. That is the strength of our study. But then of course, it is time consuming, it is costly. And of course, the vision has been measured in people's homes, so there will be an inter-observer variation. But then we know healthy eyes finally lead to a happier life. And primary eye care, as all the stalwarts in the room know, is the basis for delivering good secondary care, for delivering good tertiary care. And finally, there has to be a backward linkage for low vision rehabilitation. We have to go back to the community again, which is what the Vision Center approach helps. And this could not have been possible because we literally had so many people who volunteered, who paid, and who helped. And of course, our paying patients who kind of cross-subsidized this study, and Operation Eyesight Universal, who gave us their technical assistance. Thank you.
Thank you very much.
Thank you very much. Could you please be seated? We'll take 5 minutes to tabulate. In the meantime, if you want to have any discussion, please ask any questions.
I like to request, I'm just going to call upon an eminent ophthalmologist of Central India, Dr. S.L. Adile sir. Adile sir has got a beautiful academic career of more than 40 years. He started his career as an ophthalmologist in a sub-divisional hospital, district hospital, and ended as the director of medical education. And at the same time, right now, he is the professor at the department of LIMS, Raipur. Professor Adile, I have got only one interesting question as well as I'd like to know from you. Because we are yet to prepare the map of the geographical ophthalmology of India, which is very important. And I must admit that Dr. Parikshit will also take the initiative to prepare the map of geographical ophthalmology in India. In central India, especially in Chhattisgarh, we came across lot of color blindness, lots of color blindness, which is yet to come out to the national scenario. And what we see, that the patient cannot recognize the ECRA chart, but can jolly well identify by simple woolen test, just identification of color from wool, which we like to be granted for the patient to have some primary color defect is not there. He has got So what is your comment on this particular aspect? Color vision in Chhattisgarh.
Actually, is it audible?
Yes.
Color vision in Chhattisgarh, I don't know, sir, your observation, but my observation is that it's not different than other places. It's almost the same. Maybe at some places, few number more or less, but otherwise it's almost the same as we see in national scenario. I have some queries with Dr. Parikshit and Dr. Jethani. Actually, I am not able to understand your presentation. First, Dr. Parikshit, with you. What I could understand with your paper is that there was an area, rural area. It was not covered with vision care center. You made an effort and established a vision care center. You studied the ocular status of that area, the ocular hygiene and care of that area before establishing that center. Then you studied the that ocular status subsequently after a few years. So what is the message? What is the great thing in that? See, an area which is not presented with ocular health care naturally will have a poor health, ocular health. And after establishing, if you are not able to increase the ocular health area, if there is no impact of your center, then I don't think that is a great thing. So what actually you want to say in this, what message you want to say? Because after all, the things are natural. See, in an area where there is no eye care, naturally the eye services is poor and ocular hygiene and everything will be poor. And once you establish, naturally it is deemed to understood that there has to be improvement. But what is the great thing in that?
One is the low-income area is in Pune, and it is just about 3 or 4 kilometers from Sassoon General Hospital, which is the main medical college in Pune. So even in the heart of the city, with about 400 ophthalmologists, 6 medical colleges, even then, of course, the prevalence of blindness is not very high, but it is there. And we definitely, in 4 years' time, we have been able to reduce it to half. But we have not been able to make it zero. Even for cataract still remains a significant cause of blindness. So even if we are offering subsidized surgery, later we are offering free surgery. And we do clinical audit of our surgery, so we know that the results of the surgery are fairly good. In spite of that, in the community, there are people who prefer to remain blind rather than get a cataract surgery done. And second is, women have almost 1.5 times more prevalence of blindness than men. In spite of setting up an all-woman team, having a center in the area where 60% of the OPD, the surgery, the spectacles is by women. In spite of that, after 4 years, women still have 1.2 times the blindness than men. Now, perhaps there is a social reason to it, there is a biological reason to it. We don't know, but this is what we found.
No, that is all right. But what is the reason? You don't know. The only impact of your center was that there is, the result is that the people have a good ocular health care. That's the only message. Other messages you want to say, you wanted to mention that the vision in the women was very bad as compared to the men.
Relatively, yes, sir.
Yeah. So that has nothing to do with your center. That has nothing to do with the center, establishment of center.
But after
it may be
establishing the center, it should have gone.
Yeah.
It did completely.
For that you have to have another study, whether it is prevalent more, whether it is more common in male or female. But this study has nothing to do with that. The information or take-home message I get from your paper is that if you establish eye health care in a rural area, after a few period of time, there will be improvement in the ocular health. That is all.
Yes,
that is a non-fact. That is a non-fact. That is a non-fact everywhere. Not only in Pune, you can start in Bastar, you can start in Tamil Nadu, you can start in Mumbai. So that is going to happen. Anyway, thank you. I'm sorry. I put it
There's
as
another
that's why
thing. There's another side to it that now that we're discussing vision centers and all is that I've always been very curious to know. Most vision centers do not need to run 6 days a week. Yet vision centers never tie up with other specialities. Like you have government dispensaries and polyclinics. Why can't a polyclinic culture be brought in the vision center also? Like you can use them. You should use the same vision center to test blood sugar. Now, if you diagnose a diabetic, you're chasing his retinopathy, but you're doing nothing about control of diabetes. So the coordinated method of doing diabetes is lost. So if we could have an endocrinologist team visiting there, we could have this thing. That is one. The second thing that I find very interesting is ophthalmology. We go rural, we have vision center. We built a very nice system. The LV Prasad model and everything is there. But you never see this in ENT. You don't see this in OB-GYN. You don't see this in other specialties. Now, how do the people survive in the rural areas with this? Now, supposing somebody needs to have a tonsillectomy, how is he going to go about it? So we did a little sample study, a very small sample, in a very backward area near Gurgaon called Mewat. And what we found was that when we went there and did free eye camps, they wanted transportation, they wanted food, they wanted everything. Yet when they had to have a delivery, they would go all the way to Gangaram Hospital in Delhi and have a cesarean section. So we would ask them, if you have funds for a cesarean section, why not put some in eye? They said, why? It's a government program. It's a free program. Why should we put money in eye? So my question is that apart from doing good work, are we making the community dependent on a free service, hurting the private practitioner, same time adding to the burden of the government sector? There was a need for all this, and there is a need. But then you see, as I said, in Pune, in the same area, if you do study for, say, education, how many children are going to school? You'll find that even in the middle of Pune, people are not going to school. Similarly, if you talk about family planning, or you talk about inherited disorders, so there is hardly any availability. So in ophthalmology, we need to now start changing the model, making it more fine-tuned, that say 2-3 years you do free work, but then it should be self-sustaining. People should pay something, After all, once you start doing free work, even a 50 rupee charge looks too much to the patient to pay. And that is what I find very surprising. Yes, Dr. Gurga.
We had 30 rupees charge.
Yeah,
In
that's
fact, we have a separate study to show.
No, I'm not talking about your center. No, I'm talking about the national level. That I can still understand, like, where Dr. Swapna is, the backward areas of India still need those. There is, the Odisha belt and all that they need. But, the government has to start realizing that instead of going backward, they're making Atmanirbhar Bharat and they're extending healthcare to all. Now, I was talking to the head of health for Niti Aayog. Before the next parliamentary elections, this government scheme that come out, for the poor people, will be made pan-India for everybody. Now, which country in the world can afford to give free healthcare to all the citizens at the rate of 5 lakhs a year? You will have no money. Reserve Bank cannot print that money. So, but they say that politically it's a very wise move. It gives the impression the central government is with you. So the question is, once you start a freebie, then people find it very difficult to pay for it. And that is why all these years, we were not transferring money directly into poor men's homes and saying, here's the case. America did that and they're paying the price now. They did that during COVID. They put $2,000 in every ophthalmologist's pocket per employee, per month, so that they don't fire them. But now they have an inflation of 9% when they were having 1.5 because there's so much of money in the market. You're printing money and you're just throwing it at the people. That is what we are doing. So how are we going to sustain it? It's going to be a very major issue that time to come. Already you can see in petrol, in wheat, what is happening. We're having to stop exports. And same thing is going to happen to healthcare. It will become so cheap, so abundant that there will be no delivery possibility. It will be something like, it will be available off and on with contacts, with bribes, that sort of a thing. It will not be a universal thing which it should be.
I think there is a lacking in planning. I still believe, sir, I'm sorry, that health and education should be the responsibility of any state, be India or any. That I strongly believe. And if you go through the RMC or MCI preambles, we prepare doctor for a community. We don't write that we prepare a doctor for profession, that they flourish, earn a lot of money and do excellent job and earn a lot of money. That is not the aim of MCI or
No, doctor has nothing to do with this. This is a national program and doctor may or may not make money.
Whatever it is, government of India has spent money on you when you were trained.
So the money comes from taxpayers' money. There's a limitation
Okay, sir,
of funds.
That is what I want to say.
So
It's a
why should
taxpayer-
people who can afford to pay be given free services? That is my question.
No, I'm not telling that you give free services to the people. Let the government give free services to the people. That is
No,
what my
government is giving free services, but the government services are not adequate. Now they're bringing the private sector in by saying we will subsidize you. You go ahead. Now we are allowed to do surgeries and they reimburse you
No,
for
that is
CGH.
not well planned.
Anyway, now we don't have time
Very-
for that.
okay.
The session is
Uh,
getting
one
over,
point
so
is
we'll have a
that-
group photograph with the three finalists and the
Okay.
podium here, because at the end of the day we cannot announce the results because as per the law it comes through the AIOC headquarters.
Okay,
so
sir,
that
thank
will
you.
take a few weeks to months. So maybe earlier also. So my suggestion would be that we have a group photograph now of all the finalists and all. And it'll be very interesting presentations. They'll be very, thought-provoking.
And at the closure, I do agree with what Professor Adile told. Health and education should be free for everybody in a nation, in a developed nation. And in which way the government will support the private doctors or non-governmental doctors, that is separate issue. Suppose in NH Trust in Europe and other countries, they used to support the private doctors in some other way. But for the common people, everybody should get free education and free healthcare service.
Of course, sir, in a country where millions of billions of dollars are made non-performant asset by our Reserve Bank of India, why that cannot be used for poor people?
Yes.
Why rich people should be given so much of luxury?
Well, let's have the photograph, because the photograph will be, no, we can, I agree. I agree that Eastern India is more prone to this kind of a thought process, but you see the modern capitalistic method is that nothing should be given free is not appreciated. And that's also a fact that at the end of the day, you find the private schools are doing much better financially than the government schools are, because the rich people, even the top brass of the political class is not sending them to these schools anymore.
The private is, it's the resources they have.
That the government should prepare all this.
You can have resources in the government sector. You can have a better. You see the Jawahar Navodaya Vidyalaya, they are doing very well as compared to your.
Very few models, sir. Very few models in the country.
राहुल कहाँ गया? राहुल देशपांडे? ठीक है, ले लो।
No.
No. 420 is
420 is yet to start. You are very bold in what you stand for, so you shouldn't put on the mask.